The International Osteoporosis Foundation, the world's leading NGO dedicated to osteoporosis and related diseases, is proud to present to you today's webinar on the topic of managing osteoporosis during the current COVID-19 pandemic. Today, we will be discussing the following topics: the impact of COVID-19 on care pathway continuity, managing the patient at risk of fracture, and effective treatments to avoid fractures. Both presentations will be followed by concluding remarks and a Q&A session. It is now my great pleasure to introduce you to the first speaker, Professor Adolfo Díez-Pérez. Professor Adolfo Díez-Pérez is a clinician and researcher who has published more than 370 scientific articles in peer-reviewed journals. He is the head emeritus of the Department of Internal Medicine at the Hospital del Mar in Barcelona. He is the professor of medicine at the Autonomous University of Barcelona. He is also a member of the Research Network on Aging and Frailty of the Institute Carlos III, and he is a member of the Committee of Scientific Advisors of the International Osteoporosis Foundation. I will now present to you Professor Socrates Papapoulos, who is our second speaker today. Professor Socrates Papapoulos is an emeritus professor of bone and mineral metabolism at the Leiden University Medical Center in the Netherlands. He was trained in internal medicine and endocrinology in Athens and London, and since 1974, he has been continuously engaged in basic and clinical research, patient care, and teaching. He has also served on numerous boards and committees, including the board and the Committee of Scientific Advisors of the International Osteoporosis Foundation, the board of directors of the IBMS, the board of ECTS, and he has also been involved in the European Union Committee for the Prevention of Osteoporosis. It is now my great pleasure to leave the floor to both of our speakers today, and I hope that you enjoy today's webinar.
Hello. I would like to thank the International Osteoporosis Foundation for offering me this opportunity, and also to Amgen for making possible this seminar that will be on COVID-19 and the osteoporosis patient care pathway. These are my disclosures. And let's start by considering what is the impact of COVID-19 on care pathway continuity. And nothing better than starting with a clinical case, a 60-year-old lady with a history of multiple fractures, scoliosis, that has been on weekly alendronate for 4 years, but she got 2 new fractures while on treatment. Then, considering that it was a case of treatment failure, the patient was switched to denosumab subcutaneous injection every 6 months, and this was 23 months ago, having received up to 3 doses. This is the X-ray films of the spine in this case, and this was the history of DXA measurements, both on the spine, the head on the left, and at the hip on the right, up to the moment when was stopped the alendronate and she was switched to denosumab 1.5 years ago, a little bit more. But the problem for today is that she came to the hospital with a history of 5 days of fever up to 38.7 degrees Celsius with dry cough, general malaise, mild diarrhea. Her oxygen in arterial blood was correct, but in the chest X-ray, it was detected a mild basal infiltrate. Then the PCR for the COVID-19 was positive, and she was diagnosed of infection by coronavirus. And at this point, the next dose of denosumab for the patient was scheduled in 2 weeks. Let's stop here, considering by this patient a high risk of future fractures. Indeed, having had multiple fractures implies a increased risk of future fractures, but also when we use the FRAX tool for measuring the risk of having a fragility fracture in the next 10 years, it rates very high both for major osteoporosis as well as for hip fracture risk. This is a good point for thinking on the current expansion of telehealth. We know that telehealth is a new area that encompasses three main arms: telemedicine, remote patient monitoring, and mobile health, or the so-called mHealth. And telemedicine can be at his own synchronous or asynchronous, depending if the interaction are made on real time or are delayed after recording some of the information. The telemedicine has expanded dramatically in the last few months due to the coronavirus pandemic. And this is a document referring to the expansion of this strategy in Europe, but it's not just in Europe, but in other areas of the world. Telemedicine has been also increasingly adopted amid the pandemics and for reasons that we will see in a minute. Covid-19 has transformed then telehealth into an essential service and has changed the paradigm of face-to-face visits, leading to an increased adoption of telehealth. And what we mean by telehealth? Telehealth is the interactive electronic exchange of information for diagnosis, intervention, or ongoing care management remotely. There are several modalities of telehealth, like the real-time virtual interaction, remote patient monitoring, or the asynchronous store and forward information. And with respect to the interaction between the patient and the physician or other healthcare provider, can be done by means of virtual visits, by using wearables or home exams, or by secure messaging. In our experience, recent experience due to the pandemic, we start a hospital at home facility specifically devoted to COVID-19 patients, in which we use very common monitoring tools like oxygen monitors, thermometers, blood pressure, or controls of glucose that were provided to the patient in a way that the patient was able to measure all these elements at home. And then the interaction between the provider and the patient was based on this ongoing information to control how the patient was doing during the process. There are many potentials, like the video visits, the use of telephone, text, or email, some applications of the mobile phones, or voice interface applications like Amazon Alexa, Google Voice, Apple Siri, the use of mobile sensors like smartwatches, also by using wearable devices or introducing chatbots in the medical care, or finally, as we did recently, by implementing and expanding the hospital at home strategy for interacting between the system and the patient. And with respect to the interaction between providers, between different specialists or between nurses and physicians, etc., there are possibilities of using electronic consults, implantables, or a good way for recording or recovering second opinion consults. For example, in our recent experience, the variety of dermatologic problems that were associated with the infection of coronavirus were recorded by the patient by a photograph and sent to our hospital at home, where the dermatologist was able to have a diagnosis and also to give therapeutic orientation for the different lesions that appear in the skin of our patients. There are obvious advantages of using telehealth during pandemics. You can use telehealth for remote triage or remote surveillance, provides you the possibility of having continuity in the management of chronic disease, keeping the face-to-face visits only for the sickest patients, decreasing, therefore, the risk of person-to-person transmission, both between patients or between patients and family members, keeps also the healthcare workforce safe by avoiding the direct contact with a potential infectious person, and allows physicians that are symptom-free but in quarantine for whatever reason to provide patient care remotely, and indeed relieves the strain on the local healthcare workforces, hospitals, and primary care centers. There are several considerations about telehealth use in patients with osteoporosis. The first is the importance of continuing therapy in patients that already have established a bone health plan. And also, in patients with new fractures who require a DXA and lab test, are able to provide the tools for deciding the initiation of therapy, considering alternate options for the delivery of care. Because DXA may not be needed depending on the type of fracture. For example, if a patient sustains a hip fracture, it is not necessary to measure bone density. And also because it offers you the opportunity of using online risk calculations for helping the physician in making decisions about treatment, like FRAX, Garvan, American Bone Health, etc. Again, this is a picture of the FRAX tool that is able to make a very refined calculation of the risk of fracture in the next 10 years, even with no information about bone density, by gathering information on age, sex, body mass index, previous fracture, and family history of fractures and other risk factors that makes you offers you the possibility of having a classification of the risk of the individual patient. And this is important because we are well aware of how important is the prevention of fractures and the stratification of the risk in the given patient. We know that approximately 9 million fragility fractures occur worldwide every year. The figure is that 1 in 3 women at the age of 50 will suffer in the remaining lifetime frame a fragility fracture, at least one. And in the world, a fragility fracture occurs every 3 seconds. And these fragility fractures are not neutral because are associated with an increased risk of mortality. Here we see at different ages, from the age of 60 to the age of 85 plus, from the left to the right, that the risk of mortality in the general population in the gray bars is always overcome by the risk of dying in patients with a recent fragility fracture in the blue bars. At every age, having a fragility fracture implies an increased risk of mortality. And these fractures are associated with other consequences, like high rates of disability and loss of independence, being admitted to nursing homes or long-term care facilities, carries a financial burden on patients and caregivers, decrease the ability of performing activities of daily living. The patients become worried about falls, future fractures, and the possibility of being for the remaining lifetime in a nursing home care, and also induces other non-skeletal consequences such as chronic pain and other complications. And there are several elements that can be put in the game of the risk of future fractures. And the risk for future fractures is basically determined by a previous fracture. A prior fracture is a very powerful predictor of further fractures, but there are other elements like age, low bone density, and other risk factors that also play a role in increasing the risk of having a fragility fracture. And these other risk factors can be classified in those that are modifiable and those that are non-modifiable. Non-modifiable risk factors are gender. Female sex is associated with a higher risk of fragility fracture. Ethnicity, being Asian or white. Having a family history of hip fracture or osteoporosis, or a small body frame. But there are other factors that are modifiable, like bone body mass index, having deficiency in calcium and vitamin D, the deficiency of estrogens, an inadequate physical activity or extended bed rest, excess of alcohol, tobacco smoking, frequent falling, glucocorticoids use, and other medications potentially harmful for bone. In all these modifiable risk factors, we have an opportunity to change the risk of having more fractures in the individual patient. What we know also that in recent guidelines, like in the International Osteoporosis Foundation guideline, there is a system for understanding the future risk of fractures by classifying our patients in three categories. The first group are patients at very high risk of fracture. And this patient, very high risk, is the one that shows one or more of these elements. A fracture within the past 12 months, having had multiple fractures, a fracture while on treatment for osteoporosis, or a fracture during a medication that is harmful for bone, having a very low T-score below -3, or a fracture probability superior to 30% for major osteoporosis fracture or above 4.5% for hip fracture. A second group is patients at high risk if any of these elements is true. In postmenopausal age and above, having a prior fracture more than in the previous 12 months, or a T-score below -2.5, or a T-score in the range of osteopenia between -1 to -2.5, and a fracture probability above 20% for major osteoporosis fracture or more than 3% for hip fracture. And finally, patients at low risk are those that have all these items: postmenopausal age with no prior fracture and a T-score in the normal range, above -1, or a fracture probability below 20% for major osteoporosis fracture or below 3% for hip fracture. The guidance for making estimates and helping the clinician in our decisions about osteoporosis during the time of the pandemics by COVID-19 are provided in this link on the top of the slide, where you can find very useful information for managing osteoporosis patients during COVID-19 problems. What about our patients? Our patient was admitted because an infection by coronavirus, and she recovered well from the infection in 7 days. Fever and respiratory symptoms disappeared, and the decision that was made about the treatment for osteoporosis was to delay for an extra week the following dose of denosumab. And this decision was very well in line with recent recommendations by a joint webinar panel of the American Society of Bone and Mineral Research, the Endocrine Society, the American College of Endocrinologists, and the European Calcified Tissue Society, that has been also published in the Journal of Bone and Mineral Research very recently. And the recommendations about denosumab is that you may consider a delay in treatment with denosumab, but if the delay exceeds 1 month, you can take a temporary transition to an oral bisphosphonate. For teriparatide, abaloparatide, or romosozumab, you consider also a delay on treatment, but if in this case the delay exceeds 3 months, you can consider a temporary transition also to an oral bisphosphonates. And for those patients that are under IV bisphosphonate treatment, delays even of several months are unlikely to be a problem for that particular patient. Let's take a look to the future developments and potentials of telehealth. And I would like to remind you that these aspects of telehealth, telemedicine, remote patient monitoring, and mobile health are actually based on the development of artificial intelligence systems. And there is a very rich document on artificial intelligence in medicine and healthcare that has been published by the European Union a few weeks ago, that is accessible for free in internet. And in this document, there is a review on several elements around the development of artificial intelligence in medical care. This Joint Research Council Science for Policy report defines artificial intelligence as a subfield of computer science where machines can imitate human intelligence. And it has been estimated that only in the USA, artificial intelligence applications in medicine can save up to $150 billion in annual health costs by 2026. There are a large variety of applications of AI in medicine, like, for example, the analysis of image techniques, like radiology, pathology, dermatology, some of them already implemented in our hospitals and also in some of the telehealth service already working. Also, the development of computer-aided diagnosis, including online assistants like apps or chatbots. The development of image-guided surgery, the use of wearables, and also the Internet of Things devices that provides the possibility of real-time monitoring, even triggering automated interventions in case of emergency. Nonetheless, the design and implementation of a very highly precise and very individualized medicine strategy for an individual patient. However, we have to consider that there are also some issues of the use of artificial intelligence in medicine. Issues around data privacy, integrity, and anonymity. What are the consequences of using artificial intelligence in terms of legal responsibility and accountability? What are the potential effects on medical professionals? Because some specialties, as we know them today, may even disappear. The problems of security and reliability of the algorithms developed in artificial intelligence, the performance metrics, and the important point of keeping a human in the loop in a way that if there is some bizarre decision or some bizarre output provided by the artificial intelligence system, someone has the decision capacity to not to use what has been suggested by the system. And finally, another important problem is the cost of expanding these strategies. More fields to explore in the future that may seem science fiction today, but are under development today, are reading and decoding brain signals, interactions with neural processes, the employment of gene editing for self-experimentation or design embryos, extending personalized medicine, the integration in terms of the different demographies, social and lifestyle data, the development of sensors that are able to evaluate mood and psychosocial status, and as we mentioned, the development of interfaces to the human neuronal system. But some potential risks are also associated to the use of AI in medicine, and we have to pay attention to that and be careful for avoiding some of the potential harms, like weaponization or use of artificial intelligence health care in bioterrorism, the so-called heart transplant, by replacing the free willing of a person by developing artificial life forms, or in general, by going beyond what are the ethical limits to prevent privacy violation, manipulation of the individuals, or an over-control of the population. So, in conclusion, what we can say is that COVID-19 has changed the paradigm of face-to-face visits with patients by the expansion of telehealth and telemedicine. The decreased access to physicians during the pandemics highlights the importance of telemedicine to ensure a care continuity and fracture risk prevention in osteoporosis like in any other chronic condition. And also to keep in mind that actually we are at the beginning of telemedicine and artificial intelligence applications in medical care. With that, I would like to thank you all for your attention with this picture of my center, Hospital del Mar, that is located right by the beach in the Mediterranean in Barcelona, where all of you can be welcome anytime you want to visit us. Thank you very much.
And to thank the organizers for giving me the opportunity to communicate with you during this difficult period. In the next 30 minutes, I will briefly review the current state of pharmacotherapy of osteoporosis and discuss certain practical issues related to the use of anti-osteoporotic medications during the pandemic. The aim of any intervention in osteoporosis is the prevention of fracture in individuals at increased risk for a fracture. And these include general measures, of which vitamin D administration to correct deficiency or insufficiency of vitamin D is the most important. Then we have non-pharmacological interventions, which aim at reducing the frequency or the impact of falls. And finally, we have the pharmacological interventions, the subject of our discussion tonight. As you all know, bone is continuously renewed throughout life through the sequential action of the osteoclasts, the bone resorbing cells which remove old bone, and osteoblasts, the bone forming cells, which lay down new organic matrix which eventually mineralizes. So this is the process of bone remodeling. In the healthy adult, bone resorption and bone formation are balanced. However, in osteoporosis, these two processes are imbalanced due either to increased resorption or decreased formation, or usually both of them. And this pathophysiological basis provides the rationale for the development and use of specific medications to treat the disease. And we have the inhibitors of bone resorption, such as the bisphosphonates and the RAN-glycan inhibitor denosumab. We have agents that stimulate bone formation, like PTH1-34 or teriparatide, or the analog of PTHRP, abaloparatide. However, it is important to notice that these compounds not only stimulate bone formation, but also resorption. And finally, we have inhibitors of sclerostin, such as romosozumab, which stimulate bone formation and inhibit also bone resorption. So we have all the necessary tools to treat our patients. The question then is, how do we choose among all these interventions? From a medical perspective, we choose on the basis of the efficacy and the safety of the pharmacological agent available. When we look at the efficacy, we always have to aim at the reduction of fractures at all skeletal sites, including the hip. At the same time, we have to examine the data and look very careful at the balance between the benefit and the risk, and the benefit should clearly outweigh the risk in order to use the appropriate medication. And I would like to give you an example of that with anti-resorptives. We know that the three bisphosphonates, alendronate, risedronate, and zoledronate, and also denosumab, decrease the risk of all osteoporotic fractures, including those of the hip. However, the same can also be achieved with hormone therapy. However, it was shown that in elderly women, HRT compared to placebo increased significantly certain severe adverse events, such as breast cancer and cardiovascular events. And for this reason, HRT, once the favorite for treating osteoporosis these days, is not anymore first-line treatment for the disease because of this imbalance in benefit-risk ratio. Now, when we have these effective medications, can we choose among them? The answer is no, because we don't have direct head-to-head clinical trials among them. And why are these needed? Just to show you the incidence of fractures in placebo-treated patients in the main clinical trials with risedronate, alendronate, zoledronate, and denosumab. It is very clear by looking at the incidence of vertebral fractures and hip fractures that there is a difference in the severity of the disease of the patients included in these studies. And therefore, we can't directly compare the results. However, we have head-to-head studies with surrogate endpoints, namely bone mineral density. In a pooled analysis of 4 randomized controlled trials of denosumab versus the 4 bisphosphonates in postmenopausal women who had been previously treated with oral bisphosphonates, it was shown that denosumab increased the bone mineral density at all skeletal sites significantly more than any individual bisphosphonate or all of them together. Why is this important? Although a surrogate endpoint, it was previously shown in studies with denosumab that an increases in total hip BMD accounted for about 75% of the reduction in the incidence of non-vertebral fractures. The same is also true with intravenous alendronate, which could explain increases induced by intravenous in BMD induced by intravenous zolendronate, could explain about 61 to 62% of the reduction in the incidence of non-vertebral fractures. So we have a very valid surrogate endpoint. We do have these days, however, head-to-head studies between bone-forming agents and bisphosphonates. One of those was the so-called VIRO study, in which women with severe osteoporosis were treated either with daily subcutaneous injections of teriparatide or weekly tablets of risedronate for a period of 2 years. As you can see in this slide, compared to risedronate, teriparatide decreased significantly the incidence of new vertebral fractures. The same was also true for clinical fractures. However, there was no difference between the two groups in the incidence of other osteoporotic fractures or for non-vertebral fractures. Another study is the ARCH study, in which women with severe osteoporosis were treated during the first year either with subcutaneous injections, monthly injections of romosozumab, or weekly oral alendronate, and during the second year, all patients received oral alendronate. Again, we see here that both during the first and the second year, the incidence of new vertebral fractures decreased significantly with treatment with romosozumab alone or romosozumab followed by alendronate. And the same was also true for clinical fractures, which was a co-primary endpoint of that particular study. And you can see here the result in this slide. The lines diverge quite early, and a significant result is obtained already by 12 months, and this continues as the observations go on. Particularly important in this study was the significant reduction of non-vertebral fractures also, any type of osteoporotic fracture, and most importantly, a significant reduction in the incidence of hip fractures, which is a quite remarkable result. So we do have the tools to manage our patients efficiently. Now, do we have a comparison between the two bone-forming agents? The answer, no, we don't have a direct head-to-head study with fractures, but we do have a study in which daily injections of teriparatide were compared to monthly injections of romosozumab in women with osteoporosis previously treated with bisphosphonate, but never achieved osteopenic value. So they remained osteoporotic on treatment with bisphosphonate. And as you can see in this slide, compared to teriparatide, romosozumab increased bone mineral density both at the spine, at the hip, significantly more. In addition, hip strength estimated by finite element analysis were significantly higher in women treated with romosozumab. So with all these data, very recently, the International Osteoporosis Foundation and the ESCO circulated a guidance of management of postmenopausal women according to the risk of fracture. As discussed earlier on by Professor Díez-Pérez, now we can classify our patients as having low risk, high risk, or very high risk. And it is in this particular indication where the guidance of IOF suggests to consider an anabolic agent followed by an inhibitor of bone resorption as first line of treatment. Now, these are very important new developments. However, due to the restrictions imposed by the pandemic, these new therapeutic concepts are extremely difficult to implement at present, but surely will form the basis for new guidelines by health authorities or by professional societies in individual countries. So with this background, we need now to look at the practical issues we are facing these days. And first of all, we have to ask two important questions. The first is, are patients with osteoporosis at higher risk for infection? The Osteoporosis International produced a document where they analyzed the all evidence available and concluded that having osteoporosis does not increase the risk of contracting coronavirus or having serious complications, which is absolutely true. However, we should not forget that patients with osteoporosis, particularly those with severe osteoporosis, are usually older, and severe osteoporosis is also associated with a high frequency, a high prevalence of cardiovascular disease. So therefore, just by age and potential cardiovascular risk these patients may belong to a more vulnerable population, but not for their osteoporosis. The second extremely important question is, are the treatment for osteoporosis associated with risk for infection? A professional society of the American, a group of professionals of the American Society for Bone and Mineral Research came to the conclusion that there is no evidence that any osteoporotic treatment increases the risk or severity of COVID-19 infection. And I would like to look into the issue of infection in a little bit more detail, because it is something that concerns all of us when we manage our patients with osteoporosis. And perhaps we need first to look in the use of bisphosphonates and in a study which has been very important in understanding the effect of potential effect of bisphosphonates on an infection. This was the Horizon recurrent fracture trial, in which patients with hip fractures were treated with zoledronate infusions or placebo infusions following the repair of the hip fracture. And in this study, a survival benefit for zoledronate was observed. Trying to understand the reason for that, people have done numerous analyses, including the analysis of severe adverse events that occurred during the study. Why I'm referring specifically to this study? Because they adjudicated these events extremely carefully. Now, we can see specifically when they looked at pneumonia, the incidence of pneumonia or severe respiratory disease, we see that there was no difference between placebo-treated patients and zoledronate-treated patients. However, when they looked at the incidence of deaths among subjects with these conditions, we see that those treated with zoledronate had a significantly lower death rate than those treated with placebo. This shows very clearly that this bisphosphonate did not have any adverse effect on infection, and perhaps may have had also a beneficial effect. When we look, however, at nitrogen-containing bisphosphonate, there is something, a clinical expression of treatment that we need to take into consideration, and this is the acute phase response. All nitrogen-containing bisphosphonates, but particularly those given intravenously for the first time, may be associated with flu-like symptoms like malaise, high temperature, muscle pains, which develop during the first 48 hours after starting treatment. This response is associated with a decrease in lymphocyte counts, an increase in serum CRP levels, and also in serum IL-6 levels. And these all comprise the acute phase reaction. This effect is transient and usually does not occur upon retreatment with the same or another nitrogen-containing bisphosphonate. This is extremely important these days to tell to our patients and inform them of this potential reaction if they happen to be treated, in order not to panic that something else is going on. Now, furthermore, and quite importantly, what is the basis of this reaction? It is thought that nitrogen-containing bisphosphonates, by inhibiting their target enzyme in the mevalonate pathway, which is farnesyl pyrophosphate synthase, increase the accumulation of metabolites upstream farnesyl pyrophosphate synthase in blood monocytes. And why is this important? Because these metabolites interact with gamma delta T cells. So they bind to specific receptors and they increase the activity of gamma delta T cells, but also the proliferation, leading to increased production of pro-inflammatory cytokines. So in a way, the bisphosphonates do have an immunoregulatory function. And this is not confined only to the nitrogen-containing bisphosphonates, as it has been shown, at least in mice, that all bisphosphonates can target the B cells and enhance humoral immune responses, including the increased antibody response to live and inactive viruses, as graphically shown in this slide. So therefore, there is clearly no negative association of bisphosphonates with infection. If there is a positive effect, that needs to be shown. However, having said that, in the highly improbable case of wanting to treat a patient with COVID-19 with a bisphosphonate, particularly an intravenous, I would suggest not to do it because, as you know, there is a group of patients with COVID-19 which can develop acute respiratory distress syndrome, which is characterized by the so-called cytokine storm. And obviously, you don't want to add something more into that by giving an intravenous bisphosphonate. But as I said, this is purely theoretical and it has never been shown. And just for consideration to close this part of the story. What about denosumab? We know in the original studies in the Freedom, there was an increased incidence of skin infections of cellulitis in patients treated with denosumab subcutaneous injections. However, this was not found in any other studies or later on. So in a very recent meta-analysis of all studies that have used denosumab 6 monthly injections for various indications, there was an imbalance in infections, particularly ear, nose, and throat with denosumab. However, when they looked specifically into patients with osteoporosis, and this analysis included about 15,000 patients with osteoporosis, there was absolutely no difference between denosumab and a comparator in serious adverse events of infections. Furthermore, there was no difference in death, in the incidence of death, in sepsis, in influenza, or in pneumonia between denosumab and a comparator molecule. So therefore, we don't have really any evidence that denosumab may predispose patients to an infection with the virus. Importantly, when an analysis of studies which compared denosumab to bisphosphonates was done with an aim at looking at infections, and this analysis included 6 head-to-head randomized controlled trials. They in more than 4,000 patients. The analysis showed absolutely no difference in the infections, in severe infections between the 2 groups of patients, which is quite reassuring. And finally, a very interesting retrospective analysis was done, and this was an observational study of patients with rheumatoid arthritis, which are already immunocompromised and were receiving treatment with biologics. And they looked in these patients in a group that received denosumab versus another group that received zoledronate. And as you can see in the slide, there was absolutely no difference between the 2 treatments. Therefore, to conclude, yes, there is no evidence of an association between the agents that we're using for treatment and infection. Now, the second set of questions are related directly to the management. Shall we start treatment in a newly diagnosed patient with osteoporosis during this period? If the patient has severe osteoporosis, like a hip fracture or a clinical vertebral fracture requiring admission to the hospital, yes, we can start treatment during this admission. And this can be done with injectable medications. In patients with less severe disease, it is extremely important to start vitamin D and calcium, but treatment may be initiated later. Don't forget that the period of lockdown and in the services in the outpatient services of hospitals is about 3, maximum 4 months. So these provides enough time, sufficient time to start later with the treatment. What about continuing treatment? This should be the aim of our management. We have to use any means possible to make sure that our patients continue their treatment during this period. What about if treatment should be interrupted, for example, because infusions of zoledronate cannot be given, or injections of denosumab cannot be given, or patients stop treatment for a variety of other reasons. Now, if we look at the consequences of stopping osteoporotic treatments on bone mineral density, we see in this slide on the top that if you stop the bisphosphonate for the following 12 months, there is very little bone loss due to the specific pharmacological properties of bisphosphonates. So if you have patients treated with alendronate or zoledronate, they can wait until the lockdown finishes in order to start their treatments again. And in the meantime, and I emphasize it again, and I will do it again and again, they should go on with the vitamin D and the calcium. However, when you look at the other medications, you see that bone is lost rather quickly. And this is particularly evident in the case of denosumab, shown as at the lowest at the end of this graph. And patients lose nearly all the gain they have obtained during treatment within 1 to 2 years, due to the rebound phenomenon, as it's called, of bone turnover markers after stopping treatment. So this is an extremely important observation, and we need to take serious care of that. So discontinuation of denosumab may be associated in a few patients with vertebral fractures, particularly clinical vertebral fractures. It has been shown in the FREEDOM study that when denosumab or placebo are discontinued, there is an increase in vertebral fractures and also in multiple vertebral fractures. And the incidence is higher in patients who had already a prior vertebral fractures. And from that, you see that about 8% of patients who had been treated on denosumab and stopped treatment do get these kind of fractures. As I said, these can be quite serious clinically, and therefore action should be taken, although the frequency of the events is not that high. What can we do? The first thing that we can do is to try and ensure continuation of denosumab treatment. As we saw in the FREEDOM and FREEDOM Extension study, the bone mineral density increased progressively with denosumab up to 10 years of treatment. And this was associated with a low incidence of non-vertebral fractures. So therefore, we should do whatever we can in order to ensure continuation of treatment, at least up until the lockdown finishes. If this is absolutely impossible, if we cannot, educate the patient to inject herself with denosumab, because we used to give the injections ourselves, then we have to think of other options. And the obvious option is to give a bisphosphonate. In an earlier study, it was shown that after 1 year of denosumab, 1 year of oral alendronate, sustained the bone mineral density at the same level. In a more recent study, patients with osteoporosis treated with denosumab who reached osteopenic levels were randomized to receive either an infusion of zoledronate, a single infusion, or denosumab, 2 injections, and then were followed for up to 2 years. As you can see in this slide, following the discontinuation of denosumab in blue, there was the rebound phenomenon of bone turnover markers. Both serum P1NP and serum CTX increased highly significant, as you can see here. And this increase could be prevented by a single zoledronate fusion. At the end of the 2 years, patients who had received a single infusion of zoledronate did not lose bone. However, a very recently published study from Denmark showed that patients receiving a single infusion of zoledronate may lose bone even after 6 months after the infusion after 1 year. And this result is very different from the ones I'm showing here. The reason is not very clear, but may be related to the length of denosumab treatment before stopping it. In the Danish study, this was about 4.5 years. In the Greek-Dutch study, it was about 2.5 years. So this remains to be clarified. Finally, what about teriparatide? In the highly unlikely, this will never happen during this period, and I'm showing it just for completeness. What about continuing denosumab with teriparatide? This should never be done. Look at the red curves, and you can realize why this should be never done. So, to summarize, we have the following options. We have somebody who is treated with bisphosphonate, stop bisphosphonate. No action needs to be taken, but make absolutely sure that the patient continues on vitamin D and calcium. Secondly, the patient is treated with teriparatide, stops teriparatide either because she reached the 2 years or for any other reason. Definitely, this should be followed by bisphosphonate or denosumab. But as we saw, the loss with teriparatide is not that dramatic as it is with denosumab. But anyway, we need to do something. The urgent action is needed if denosumab is discontinued. Then our options are first to continue denosumab and do everything we can to ensure that this can be done, or to continue with a bisphosphonate. Anyway, we should not wait more than 7 months after the last injection in order to intervene. This is extremely important. This can be done. There are supporting services at present and groups in nearly all countries in your region where you can ask for help how to ensure that denosumab treatment can be continued. Because this is, at the end of the day, the most important thing. Treatment must continue. Then, for the rest, we can do our best on the basis of the evidence I just show to you. And with this, I would like to thank you for your attention and proceed now with the discussion and try to answer your questions together with Professor Díez-Pérez. Thank you. Welcome back, Adolfo.
Hi.
Now, we have received a number of questions here, and we'll try to address all of them, but I'm not sure we're going to succeed. But we'll do our best to address at least those related to the topics of the presentation of today. So, there are a few that have to do with the use of denosumab in COVID patients. For example, Adolfo, it says here, is denosumab injection contraindicated in a patient with COVID-19?
Okay, the short answer is no. They are data stressing that for viral infections, a variety of viral infections, denosumab has no deleterious effect. And all the data on safety in all across the different studies have been very reassuring also.
Good.
However, having said so, possibly during the acute phase of the infection, in the middle of a very aggressive inflammation or a bilateral pneumonia with respiratory insufficiency, it's advisable to delay denosumab for a period of time no longer than 1 month.
Okay, can we say that obviously this is not the time to give any anti-osteoporotic medication at this time? If they are with pneumonia, it's the last thing they are going to think about is the anti-osteoporotic medication. And I stressed also in my discussion that this is also a bad time to give a bisphosphonate, because in some patients we see the acute respiratory distress syndrome with the a cytokine storm, and you don't need to add some more cytokines with the acute phase response from the bisphosphonate. So I think that we answered this particular question, and also another one which asks whether denosumab reduces the self-defenses against COVID infection. And I think Adolfo Sanz covered that, and in my presentation also we did that. So then is another question. Denosumab began in high-risk patients. How long should we use it? We know that we can use it for at least 10 years. The studies have been done. We know that for 10 years, there is a continuous increase in bone mineral density, both at the spine and the hip, and the rate of non-vertebral fractures remain low. Now, if we come to the point where we are able to define a treatment target, then we may be able to modify that. But for the time being, at least 10 years, is we can treat our patients, particularly those with severe osteoporosis. Do you agree, Adolfo, on that?
Yes, yes. Sometimes you wonder if a patient has been for 10 years with denosumab and is doing well, and the bone density is still not in a highly comfortable level. Possibly you might, if the patient again is doing well, you might expand a little bit more the treatment, because there are no formal studies, but report of cases in patients that have been treated for 12, 13 or more years with no problem at all. So it's like the uncertainty of not having a strong evidence beyond 10 years, but then is when the clinical judgment can help you in deciding if a patient can still be for a longer period of time than that on denosumab.
Excellent. I hope that we provided an answer to this particular question. And now I have a very crucial, practical question, which I believe we addressed, but we can repeat it because really it's very important. Somebody asks that according to ACR, we can wait up to 8 months before we give the next denosumab injection. Do you agree with this statement at all?
I'm afraid I don't completely agree. The joint webinar and then the paper published by the American Society, ACR, Endocrine Society, and ACTS stated that you can delay up to 7 months. That is 1 extra month above the usual 6-month period between injections. After this extra month, I mean after 7 months of the previous dose of denosumab, probably is better to switch, at least temporarily, to an oral bisphosphonate.
Okay, fully agree. It's not yes, but. Okay, 7 months is the period. The reason there have been cases of vertebral fractures occurring 8 months after the injection. So 7 months is the cutoff point. Don't forget this particular message. Now, another question that I think you dealt with in your presentation, somebody is asking about the acceptable duration of downgrading teriparatide in patients with COVID-19. I suppose downgrading, he or she means not to give it on a daily basis or something like that, I suppose.
Or maybe switching to another drug, because the evidence about teriparatide is based almost 100% on the daily dosing. Therefore, we go back to the recommendations by the ASBMR, ACR, Endocrine Society, and ACTS that advises that if you have to stop one of those drugs, and in particular teriparatide, you can stop for 3 months. Longer than that, again, the reason for not facing a potential rebound effect is behind the recommendation of switching, again, maybe temporarily, to an oral bisphosphonate.
Okay, these are, of course, estimates. They're not based on real detailed studies. However, it makes sense from the point of view. Those of you who remember the slide I showed with the bone loss following discontinuation of various treatments, you see that the loss after stopping teriparatide is less than that. I mean, the rate of loss than that of denosumab, indicating that perhaps you can wait a little bit before you start treatment with something else, or continuing treatment in case that you stopped it for other reasons. Okay, and as said, the best with these medications is to make sure you continue them. Either this is denosumab or it is teriparatide. If you're forced to stop, then under these conditions, as we said already before, 7 months for denosumab, perhaps up to 3 months for teriparatide. And then
a comment about that. If you are forced to stop treatment for osteoporosis for longer than 3 months, it means that the COVID infection has been extremely severe. Patient has gone
to... but it may be also that they don't have the possibilities to treat the patient, so that the COVID patient has recovered, is ready to go home, but because of the lockdowns and the closures, they can't do much.
Yeah, well, it depends also on the different countries. If you can self-inject the drugs, or you need to go a healthcare provider for that. But in most of the countries, the denosumab and teriparatide can be self-injected.
Excellent. This is also a very important message, because people who are looking at the American websites get a different impression, because in the United States, denosumab is administered only by physicians, whereas in our part of the world, in your part of the world, these can be self-injected. And in fact, there are supportive services for patients who may have problems to do that. Actually, I have met now patients during this pandemic that they were on the phone or video calls or WhatsApp with their patients, showing them, illustrating how that they can self-inject denosumab. I've seen my younger colleague showing that to his patient, on the WhatsApp. So therefore, this is feasible and can be done. Okay, and it is all up to us and how much we want to help our patients during this difficult period. And at the end of the day, it won't last forever. We see that in many hospitals now, normal services have started to resume again. So things are happening. Okay, so don't take the extremes. Now, I have another question which deals with the effects of vitamin D. Somebody asks about, do we know what the effects of vitamin D in COVID-19 patients are? Symptomatic, asymptomatic, mild, with severe degree of the disease, high-risk people? I mean, in general, the question is, do we know anything about an effect, a specific effect of vitamin D in COVID-19 patients? Do you know of anything specifically, Adolfo?
First comment is that in our experience in my hospital, we systematically measure vitamin D in our COVID patients. And in almost all of them, we supplemented with vitamin D because the prevalence of deep deficiency or even depletion is extremely high. Therefore, by covering a deficiency in a physiological hormone like is vitamin D is probably a wise decision. Then it comes the debate if this is helping in terms of improving the self-defenses against infection, the immunity, modulating the excessive aggressive cytokine hormones, etc. And I will say, and I don't know if you agree, that the jury is still out.
Yeah. The long story of vitamin D, that it is a fantastic medication for everything. Now, it may be true. We don't have the hard evidence for that. However, the hard evidence is that our patients need vitamin D, not just specifically for the COVID. Perhaps it may help the COVID, that we don't know. But definitely they need, and we must make every effort to cover our patients at least with vitamin D during this period. Don't forget, everything started, in February, March. The lockdown started there, where is the lowest level of 25-hydroxy of the year, and it goes further down, and therefore it is essential and critical for our patients to receive at least their vitamin D.
Now, there has been some publication establishing a correlation between those countries where levels of vitamin D are lower, and I am referring to Spain, France, and Italy, and linking those low levels at the population level with a higher rates of infection and mortality. But again,
that goes too far, I think.
are extremely tricky.
Yeah, it is extremely, I fully agree with you. However, from a practical point of view, we said, and don't forget that in the area of the world that we are addressing today, the prevalence of vitamin D insufficiency and deficiency is much higher than in other parts of the world. So if you have to treat your patients under normal conditions, you have to do your utmost best during the pandemic to ensure that your patients do receive vitamin D.
Absolutely.
Okay. That is, I believe, a very important practical message. Then we have a question about combination therapies with denosumab, bisphosphonates, and teriparatide. The colleague who asked the question does not specify whether he or she refers to combination therapies during the COVID endemic or in general. Let's see if we can say something. Can we say something about combination therapies in the COVID era?
No.
No.
I don't know any paper, any publication on that.
And it makes it even more complicated and difficult. If we're talking about that somebody has a problem in injecting denosumab, you can then understand that if somebody has to inject the daily teriparatide and then to the denosumab and so on, it may be more complex than it looks like. However, I would like to make only one comment here. If we talk about combination therapies, the only combination therapies between the three compounds is between denosumab and teriparatide.
Yeah.
The combination of bisphosphonate with teriparatide does not add anything to the effect of either drug alone.
Yeah.
And the combination of denosumab with bisphosphonate doesn't make any sense.
No.
Therefore, when we talk about combination therapies, either in general or perhaps also during this period, the real combination therapy would be with denosumab and teriparatide. Agree?
Yes. A small comment on that. When if you have romosozumab available,
they didn't ask us. They didn't ask us. But this is a very good point. Please make it. Please, because perhaps in their part of the world is not available. That's why.
Yeah, but where it's available, actually, you combine both mechanisms of action, the anabolic and anti-resorptive. So, in some way, it's not exactly the same effect, but in some way, it's offering a combined therapy in the both sides of the remodeling cycle.
Excellent. Excellent comment. And don't forget, as I showed to you, romosozumab, in terms at least of bone mineral density changes, induces much higher changes than teriparatide alone. So you can imagine if you combine teriparatide with denosumab, you may reach the same kind of levels you can reach with romosozumab. Okay, this is a very good one. And now I have a question. This is my favorite. Whenever I am in your part of the world, ladies and gentlemen, I always wait when this question will come up. And this has to do with the duration of therapy of osteoporosis. It is a standard question. How long do I need to treat osteoporosis? I'm sure, Adolfo, you are also frequently faced with this question. And I have a very straightforward answer. Do you ever ask somebody with diabetologist, how long should you treat diabetes? How long should you treat hypertension? Osteoporosis is a chronic disease requiring lifelong chronic treatment. Do you agree with that?
Is my standard answer also. As long as you treat...
We agree on that. Yeah, no, so you see, the point has emerged. Now, if we take it, has emerged because in osteoporosis, I mean, we don't appreciate. We have fantastic molecules to treat our patients. We can give them daily, weekly, monthly, 6 monthly, yearly, or even longer than 1 year. There is no other specialty in medicine, in internal medicine, that has these, if you can say, luxury in treating their patients. The second thing, because of the specific pharmacological properties of bisphosphonates, we are in a position to stop sometimes our treatment and follow our patients without a new intervention. But this is due to the specific intervention we are using, not to the disease itself.
Yeah.
Now, if we find finally, because work now and research is moving to identify a target to treat, to reach with treatment, if we reach that, then again, we have to follow our patients. Perhaps we may not give them something for some time, but we have to follow. So management is lifelong. And I hope that these messages get across to everybody. Now,
there is an example that we could use. In osteoporosis, we don't have still a recipe to cure the disease.
Yes.
But we can reach long-standing remissions. But as in any other disease where you are able to reach a long-standing remission, you still have to follow up the patient and to monitor the disease.
Exactly. It is the typical example now. The rheumatologists, after being hopeless for many, many years with the biologics, now they have changed the whole scene, and they have a target to treat, and they can give the right information to their physicians, how to do it. And we are moving to this direction as well. The only problem is that they do have very easy to assess, whereas ours most probably going to be a measurable target. And I think with this, we came to the end of this session. I apologize if there were a few questions that we didn't manage to address. It was not intended to exclude them. We went through them as we were receiving, as they were coming in, and I hope we managed to answer at least the majority of them. And I would like to thank my friend here, Adolfo, also.
Thank you, Socrates.
It's like a privilege. It was great fun for us to do it, and I hope that you all enjoyed today's session. Please, 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 don't forget to fill in the evaluation forms. These are crucial for the organizers in order to be able to plan, potentially to plan other such meetings. Don't forget that the experience in these webinars is not that great. And so every feedback we get from you is highly appreciated. Please fill in the forms at the end. So, and with that, I would like to say good night to all of you. Good night, Adolfo.
Good night, and thank you very much for the questions.
Thank you all for your participation. And also the technical people who did a fantastic job to bring it up today. Thank you all.
Thank you. Bye-bye.